Welcome. Good afternoon for those in the East Coast. Good morning for those in the Central or Pacific time. We have over 120 registered professionals have registered for this webinar. And on behalf of the Emory Diabetes Training Academy, we would like to welcome you to this new webinar series 2019. First, I would like to say thank you to Ina Flores and Denise Porras, who are running this program, education program at Emory during the last few years, for putting these webinars together. We're going to have monthly webinars. Today we're going to discuss standards of medical care in diabetes, and we're going to discuss the American Diabetes Association and the American College of Endocrinology recommendations. What's new, what has changed, and more importantly, give you the rationale where these changes come from. Next month, in February the 22nd, we're going to have a review on the use of pumps and continuous glucose monitoring for the primary care physicians. Most of these tools are used in patients with type 1, but we're going to give you very practical insights on what the field is going on technology in pumps and CGMs in the hospital, and not in the hospital, in ambulatory and also in the hospital setting. In addition to the webinars, we would like to invite nurses, dietitians, and physicians who would like to become certified diabetes educators. The Emory Training Academy has four 3-day courses on an update on diabetes with the goal to prepare professionals to be ready to take the CDE exams. Those are going to be held in February 25th to 27th, in the month of May 13 to 15, August 26 to 28, and November the 18th to the 20th, just before the holidays. Well, the other thing is that I want to remind you that we're going to provide you with CME credit for physicians, nurses, dietitians, nurse practitioners, and pharmacists who are participating in this conference, in this webinar. Ina is going to provide some details after the lecture, how you can get your CME credit. Well, first, let me introduce myself. I should have done it before. I'm Guillermo Pierres. I'm a professor of medicine, and I'm director of the clinical research at the Diabetes and Metabolism Center at Emory. I've been affiliated with Emory for the last 30 years, and and I'm the chief of endocrinology and diabetes sections at Grady Healthcare System. So let's get started. Before I do that, something is going on. It's frozen. My apologies. We're here. I have to sorry for that. I have to present my potential conflict of interest. I'm an editor of the BMJ Diabetes and some of the therapies for diabetes textbooks for the American Diabetes Association. I'm a board member of the American College of Endocrinology, and I have received funding for research to Emory University. The money doesn't come to me from different companies for investigator-initiated research studies. I'm also a member of the ADA Professional Practice Recommendation Committee and also a member of the ADA-AACE Guidelines Writing Committee. But whatever I'm going to say today, it is my point of view, a summary of these guidelines, and I'm not representing the ADA or ACE in this presentation. So guidelines. When you talk about guidelines about diabetes, there are over 46 different guidelines. And there are some difference between them, but likely they all have the same concept. We want to provide simplified recommendations to help primary care providers, nurses, and everybody who is involved in diabetes care to maximize the treatment of diabetes. Today we're going to discuss mainly the standard of care 2019 and also the ACE 2019 recommendations. So people ask all the time, how is this concept of how we get together with the standard of care? So there's a group of about 12 professionals that have been selected. We serve for a period of 3 years, and we meet every 2 weeks on the by telephone and 2 or 3 times a year in person to discuss where we are with different areas of medical fields in the area of diabetes. The Endocrine Society has what is called the American Association of Clinical Endocrinologists. We meet by telephone several times a year, and we divide the areas with different experts in diabetes care, and we make the recommendations that are published on a yearly basis. So the standard of care is over 150 pages. So there are too many recommendations. Today, I chose to present to you where we are with the diagnosis of diabetes, prevention of type 2 diabetes, what are the recommended glycemic targets, and the pharmacological approaches for glycemic treatment and cardiovascular disorders. So when you talk about classification of diabetes, that have not changed for the last 30 years. We have diabetes type 1 that is associated with autoimmune destruction of the beta cells. Saying that, 15% of patients with type 1 diabetes do not have antibody positive. But the clinical characteristic we will discuss in a minute. We have type 2 diabetes that account for 90 to 95% of the patient that is associated with a combo of decreased insulin secretion and impaired insulin action. Gestational diabetes and secondary type of diabetes like monogenic diabetes, exocrine deficiencies, drug-mediated diabetes. So type 1 diabetes, what is new? The new thing is that we have divided now or in stages type 1 diabetes. Not everybody with type 1 diabetes is the same. And stage 1 is the positive antibodies. So you still have normal blood sugar, you respond very well to a glucose load, but you have autoimmunity. Stage 2, you have autoimmunity followed by dysglycemia. And stage 3 is where we see in clinical practice the patient presented with hyperglycemia, and 40% of patients, especially children and adolescents, present with diabetic ketoacidosis. So why is the importance of this staging classification? Because what we want is to detect patients at early stages. So the first patients can be referred to specific centers that are doing diabetes prevention for type 1 diabetes. Second, and perhaps more important, is that if I know that my child have a positive antibodies, if you have 1 or 2 antibodies positive for GAD or islet cell antibodies or insulin antibodies, about 80% of kids are going to develop overt diabetes within the next few months or years. So I can be educated to recognize symptoms of hyperglycemia. Let's say, for example, a kid who didn't pee at night and now start urinating at bedtime or during the night, or changes in behavior. So the family can be recognizes this and avoid diabetic ketoacidosis. A well-educated family should not allow the kid to develop DKA. And remember that DKA is the #1 cause of mortality in patients and adolescents and young adults. So we want to recognize type 1 diabetes early on. So the other thing for type 1 diabetes is that because there's the sudden presentations in most cases, hemoglobin A1C is not a good diagnostic tool. You have to use blood glucose concentration. And as I mentioned before, we want to screen family members with type 1 diabetes. First degrees, family members, sister, brother with type 1 diabetes, to recognize the rest of the family who are at risk of developing type 1 and its complications. What about for the rest, for type 2 diabetes, or for anybody who has diabetes? These to the To your left is the criteria that we have right now: a fasting plasma glucose greater than 126, a 2-hour oral glucose tolerance test greater than 200, and hemoglobin A1C more than 6.5. Or anybody who has a single glucose greater than 200 milligrams per deciliter with symptoms: polyuria, polydipsia, weight loss. So what is important here to your right is that all of these tests are the same. They have the same value. However, if they are not, all the tests are going to be positive in the same individual. So what is new this year is that 2 tests is better than 1. So it's better to have a blood glucose high, more than 126, and a hemoglobin A1C greater than 6.5, and you can make a diagnosis on the spot. Otherwise, if you have a single elevated hemoglobin A1C more than 6.5, you need to have to repeat that test, or you need to have a secondary test. You have to bring the patient back. The diagnosis of diabetes is a serious diagnosis. If you tell me that I have type 2 diabetes, you're telling me that my lifespan, my expectations of surviving is going to be short by somewhere between 6 to 8 years. And I'm going to undergo a lot of diet and modification of my lifestyle. So the diagnosis needs to be confirmed in 2 tests at the same time or different days. The other thing is the controversies about hemoglobin A1C. Oh, big discussion at the national meetings. Because we now know that African Americans or Black patients in general have higher hemoglobin A1C compared to Caucasians. For example, here you see to the left is the blood glucose concentration going from 100 to 350. And you have the hemoglobin A1C value for Blacks and whites. There is to the right, the last column to your right, about 0.4 to 0.5% higher hemoglobin A1C in Blacks compared to white at the same blood glucose concentration. So we debated, should we have different hemoglobin A1C cutoff? And the answer is no, that we want to make sure that you are aware of this and you want to have elevated glucose levels, because a 6.6%, you have to repeat it to make sure this is the same for all, that the value is elevated before you make a diagnosis of diabetes. Let's move to a topic of great attention in the last few years, is prevention of type 2 diabetes. Who needs to be in this category? Anybody who has prediabetes. Why? Because prediabetes has a 5 to 7% chances, a patient with prediabetes, 5 to 7% chances per year to progress to diabetes. If you tell me that I have prediabetes, it's very likely 30% to 50% patients like me will develop type 2 diabetes in the next 5 years. So we have 30 million Americans with diabetes. We have 75 million Americans with prediabetes, and we need to recognize them because interventions are effective. So the criteria for prediabetes are impaired fasting glucose, are those who have glucose between 100 and 125, a 2 hours glucose on the oral glucose tolerance test between 140 to 199, these are called impaired glucose tolerance, or a hemoglobin A1C of 5.7 to 6.4. Again, if you have anybody, you have to repeat the test, or if you perform these 2 tests at the same time, you can confirm the diagnosis of prediabetes. And who should be tested? Anybody who is overweight, BMI greater than 25, if you are Asian, more than 23, anybody who has family history of diabetes, anybody who has family history of hypertension, vascular disease, women with polycystic ovarian disease, physical inactivity, or situations associated with insulin resistance, such as acanthosis nigricans, this darkening of the skin and the neck and the arms and the axilla. In a patient with obesity, likely has prediabetes or diabetes. And as I mentioned before, prevention is important. Now we know with the diabetes prevention studies and several international studies have shown that you can prevent diabetes. If you lose 5 to 7%, so somewhere around 4 to 8 kilos, the chances that you will develop diabetes if you do regular exercise is cut down by half. So physical activity, diet and exercise is important. How much exercise? Somewhere around 150 to 180 minutes a week. So 30 minutes a day, 5 to 6 days will be enough. Why that it works, exercise, is because it makes your body to be more sensitive to the insulin that is produced by your pancreas. So in prevention of diabetes, who are the most important candidates? BMI and family history, where if the patient cannot do exercise or cannot lose weight, you should consider medication. And metformin, although not approved by the Federal Food and Drug Administration, the FDA, metformin now is recommended by most of these societies as a true and available intervention to prevent diabetes. Metformin reduces the risk of diabetes, especially in the young, overweight person, in about 30 to 40%. So, important also is that if you use metformin, the new recommendation since last year is you must check vitamin B12. We don't do this on a routine basis in the patient with diabetes, but we must, because there are several publications that have shown that levels of vitamin B12 are diminished when you use metformin long term. So if that's the case, low vitamin B12 has been associated with neuropathy, increased risk of fall, megaloblastic anemia, and can be prevented by a single blood test. What about glycemic targets? So here you have ADA to the left, American College of Endocrinology to the right. And for most patients, the ADA says hemoglobin A1C less than 7. If you think that your patient is going to have a survival of more than 5 to 10 years, the hemoglobin A1C less than 7 is the goal. In patients who are terminal with multiple medical illness, perhaps in 7 to 8% is adequate. What we want at both ADA and ACE is take in consideration the side effects and hypoglycemia. ACE proposes why stop at 7? Because now we have multiple medications that are not associated with hypoglycemia that will benefit your patients. So we're going to talk about hypoglycemia in a couple minutes. But if you have a 7.2, you start somebody on metformin, a drop below 6.5, good. If the patient is asymptomatic, because the lower the hemoglobin A1C, the lower the chances to develop microvascular complications. The ADA have pushed for this graph now for several years, and it says that you have to individualize care. You should be less or more stringent, so less or more aggressive in reducing hemoglobin A1C according to the presence of hypoglycemia, diabetes duration, life expectancy, as I mentioned to you, the presence of comorbidity, vascular disease, and resources. So what is the problem with this? That there are patients who present like this. Yeah, no major risk of hypoglycemia, good life expectancy, lack of resources. But the next patient may present in the similar clinical characteristic, but they have more hypoglycemia. So you have to individualize care. Nobody can tell you what is the hemoglobin A1C target for an individual patient, but you, after talking to your patients and consider these characteristics, risk of hypoglycemia, presence of comorbidities, and then you decide if you want less than 7, 7 to 8, or even more than 8 on a specific patient. How do we achieve goals? So pharmacological approaches, there are 12 different groups of medications that we have right now for diabetes control, 12. So what is that problem? Is that many primary care providers or nurses or nurse practitioners say, well, which should I start? Which agent is the best? So all of them dropped the blood glucose. That's why they were approved by the FDA. So the current recommendations is to start with metformin, but if that's not enough, you have to choose different combinations of agents with different mechanism of action. So currently we have metformin, who works especially in the liver, decreasing the increased or exaggerated hepatic glucose production. And that's the main reason why somebody becomes hyperglycemic, especially during the fasting state. So metformin, some other agents also work here. We have now medications who work on muscle, increasing insulin sensitivity. We have several medicines that increase insulin released by the pancreas. Other agents who decrease the absorption of glucose by the intestine, fat abnormalities, and of course we're going to discuss also the SGLT2 inhibitors that work by increasing glycosuria. So where do we stand? As I mentioned to you, metformin, the #1 agent, has been around for more than 40 years, is effective, it works fast, decreases hemoglobin A1C 1 to 2%, and you don't have to wait too long. In a matter of a few days, you see the response. And important, it's not associated with weight gain. Some people even lose a kilo or two, have good effects on macrovascular disease and lipid disorders, and have been shown to be cardioprotective. And more importantly, it's free or less than $5 a month. Some people say, this is the best agent. Nobody can beat a $4 a month effective medication for diabetes. But has some disadvantages or some things that we have to keep in mind, such as the high rate of gastrointestinal side effect, adverse events, especially during the first few weeks of therapy. Second, it's contraindicated in patients with kidney disease and shouldn't be used if the GFR is less than 30. And it should not be used at maximal dose, max of 500 milligrams twice a day in patients who have a GFR less than 45. So the risk of lactic acidosis is minimal, except for if you use it in patients who have kidney disease, severe kidney disease, or hypoxemia, such as congestive heart failure. But metformin is cardioprotective. And here you have the result of the UK PDS that shows a significant reduction of the risk of myocardial infarction here to your left compared to conventional therapy and intensive that includes sulfonylureas and insulin. And to the right is 10 years after initiation of the UK PDS, you still can see that the beneficial effect of metformin in decreasing myocardial infarction or ischemic events. So the public has listened, and this slide shows, published a couple of years ago, or maybe a year ago, that the percentage of patients who are treated with metformin, about 80 to 90% of patients are treated now with metformin in this country. So it's good. People have accepted the recommendations. Keep in mind what I mentioned to you is that the intolerance to the medication. So I can never stop telling my students and residents and fellows that you have to start slower dose. There is no rush. Start with 500 milligrams after dinner, in the evenings. The next week you increase to 500 milligrams twice a day. And you can increase to 1 gram twice a day if tolerated. There is no need to increase beyond 2 grams a day. You don't get much, but more than just side effects. And do not rush, because if the patient develops nausea, vomiting, or diarrhea, they will be scared and they will never take it anymore. And you lose the ability of using the best medication that we have. So after metformin, we have several other agents. And the current recommendation said if you fail to metformin, combine it with sulfonylureas, TCDs, DPP4, SGLT2, GLP-1, or even insulin. So how do we choose? So what about sulfonylureas? So you have insulin secretagogue, that's right, the long-acting, the short-acting sulfonylureas And you can also put here the insulin, the short-acting insulin secretagogue, like repaglanide, that is available. So the good thing, sulfonylureas, they work fast. They decrease hemoglobin A1C equal to metformin, 1 or 2%. They're very cheap. They're generic, less than $5 a month, and you just give it once a day. So it's great. But there are disadvantages, and the most important disadvantage is hypoglycemia, who have been shown, especially in elderly people or patients who have kidney issues. And you should be aware of that with those who don't eat or skip meals on the regular basis. So you have to be concerned basically with renal and hepatic disease. And there's a lot of questions about cardiovascular safety. How come? Oh, they are being used all over the world. In Asia, 70%. In the United States, about 30% of patients, although in blue you can see the number of people taking sulfonylurea has come down, you still see that about 40–50% of patients combined with metformin, second-line agent is the use of sulfonylureas. So it's worked well to me. I just select the patients and I don't use in those that I think are at risk of hypoglycemia, such as the elderly, the kidney failure, those who skip meal, those who are fragile. What about Pioglitazone? It's the only survival of the group of thiazolidinediones. We used to have troglitazone, taken away because of liver issues. We used to have rosiglitazone, not used because of some questions about cardiovascular safety. But Pioglitazone works well. It improves insulin sensitivity, make the insulin that your body produces to work better. It reduces hemoglobin A1C as good as metformin, 1 or 2%. It doesn't work fast. It's slow onset of action, and the maximal effects is not seen after 8 to 12 weeks. But it doesn't produce hypoglycemia, and it's now generic, and it's once-a-day medication. And there are some studies that may suggest cardiovascular protection. So it's a good medicine. The problem is the disadvantages of the adverse events. So it produces weight gain. So if you tell me that I'm going to start taking a medication that is going to make me gain 1 to 3 kilos, it's not on the top of my list. Or it produces edema because of fluid retention, and it may be associated with patients with heart failure. So it should be kind of used with caution in this group of people. And lately, in the last 5 to 10 years, we've learned an increased prevalence of osteopenia with increased risk of fractures, especially in postmenopausal females, in patients taking TCDs. And in some countries, they have not been available now in the market because of the issue of bladder cancer. So TCDs are good, cheap, effective, but they have side effects. So if you use Pioglitazone, please do not use more than 15 milligrams, and for sure no more than 30 milligrams, and avoid the higher doses because the side effects are quite large. What about DPP-4? Oh, people like it. There are very little side effects, no hypoglycemia, no weight gain, is weight neutral. Minimal side effect, can be used alone in combination with different medications. The problem with this medicine is the potency is not that great. The potency of this medicine, they reduce hemoglobin A1C about 0.4, 0.5, 0.6, and they're very costly. But in the elderly, in patients who have mild hyperglycemia combined with metformin, is absolutely fantastic. So there are other medicines that we're going to discuss in a minute, like the SGLT2s, oral medicine, increased glucose excretions in the urine. And you see that all of them, here I only have Cana, glifloxin, dapagliflozin, empagliflozin, but I can also say that ertugliflozin from the Merck product is about the same. It reduces hemoglobin A1C about 0.6 to 0.9% in more patients. And because it produces glycosuria, you lose calories, you lose glucose in the urine. Glucose in the urine means caloric flush, calories flush in the urine. People lose it somewhere around 1 to 3 kilos. And because it's an insulin not mediated glucose regulation, it's not associated with hypoglycemia. So it's great medicine for the use. And finally, we have the GLP-1. That's right. GLP-1 has been available now for 12 years. We have several of them. It can be given once a day to once a week. And they're all very similar. Produce hemoglobin A1C reduction between 0.9 to 1.2. And like all the medicine, the higher the hemoglobin A1C when you start, the more greater effects on reduction of hemoglobin A1C that you're going to see. And these medicines have also been shown, the GLP-1, similar weight loss with most of them, and you see that they lose between 2 to 4 kilograms. So it's very attractive for a lot of patients. So GLP-1, SGLT2 is very good. They reduce hemoglobin A1C, low risk of hypoglycemia, and with the SGLT2, you have to be careful. It cannot be used in patients with reduced GFR, and they both have cardiovascular protection. So how often they're used, SGLT2 is about 8 to 10% of the population now is taken, but you have to be concerned on genital myocardial infections and the increased risk of urinary tract infections. And in some patients who are going to be NPO, there may be a risk of diabetic ketoacidosis. And in patients who has ulcers in their foot, diabetic foot lesions, and been associated with increased risk of amputations. So these medicines have really changed the way we treat medicines. So now we have reviewed how they work, how they are, which one they are. So what are the new recommendations from last year? We said in the standard of care, metformin is the way to go, no question. And instead, like we used to do any one of these medicines, we want you to ask one question. Does your patient has coronary heart disease or cardiovascular disease? Stroke, heart attack, peripheral vascular disease? If the answer is yes, instead of going to sulfonylureas or all of the other choices, the new recommendation this year is that you should choose a GLP-1 or an SGLT2. So you have a patient taking metformin, hemoglobin A1C 7.8, the patient has coronary heart disease, you should do GLP-1 or an SGLT2. If the patient has heart failure, we recommend you to start an SGLT2 because SGLT2s, in addition to produce glycosuria, it produces natriuresis because inhibit the absorption of glucose and sodium. And by producing natriuresis, you lose salt in the urine, your blood pressure comes down, heart failure gets better. If you have a patient with ischemic vascular disease or atherosclerotic or stroke, the GLP-1 receptor analog may be the first line agent. It can be once a day, it can be once a week. But many of you think they are very expensive. So if cost is an issue, a lot of my patients do have metformin followed by sulfonylureas or TCDs. But if you use sulfonylureas, keep in mind, use the lower dose, be aware of the hypoglycemia. If you use TCD, keep in mind that they may produce weight gain, they may produce heart failure, and in patients who have osteopenia, osteoporosis may not be the greatest drug. If metformin, sulfonylureas, or TCDs are not enough, you can use NPH insulin if you want to do it. You also have to be concerned about hypoglycemia. So if there are agents that do not produce hypoglycemia, like the DPP-4, GLP-1, SGLT2, or TCDs. And to the right is weight gain. Remember that sulfonylureas and TCDs produce weight gain, and GLP-1, SGLT2 produce weight loss. So again, what are we saying? That you should start with metformin and then ask, does my patient have ischemic heart disease, heart failure? You choose GLP-1, SGLT2. But 75% of your patients in your office do not have active heart disease. So in those cases, you should choose whatever else is in the armamentarium of medications for treatment of diabetes. In front of you are the algorithm, the 2019 algorithm for the American College of Endocrinology. And this says that if you have a hemoglobin A1C less than 7.5, you should start on metformin, followed by GLP-1, SGLT2, DPP-4. And the others have a little yellow dot is because of side effects or hypoglycemia risk. If the hemoglobin A1C is greater than 7.5, you should start on dual therapy, or if you fail with one agent, you should combine metformin plus GLP-1, SGLT2, DPP-4, or TCDs. You can also move to triple therapy, and you can also use basal insulin in these patients. We want insulin to be used in everybody who has symptomatic diabetes. If you have a patient present with polyuria, polydipsia, weight loss, start on metformin, start with insulin. And after a few weeks, when glucose toxicity has resolved, you can switch them back to combination pills in most of these patients. Remember, hemoglobin A1C, a high hemoglobin A1C above 9, 10, 11, in asymptomatic diabetic patients, insulin is incredibly effective in improving diabetes care. Finally, let me discuss with you new events on cardiovascular disease prevention or risk management in patients with type 2 diabetes. Where do we stand with blood pressure? We want the blood pressure, according to the ADA, less than 140/90. But if you have somebody with proteinuria, with many cardiovascular risk factors or cardiovascular disease, maybe 130/80 is indicated. But in a young person, 45, 140/90 may be okay. The American College of Endocrinology still recommends 130/80. The American Heart Association, 130/80. So in my practice, I use 140/80 for most people. But in those who have proteinuria, kidney disease, heart disease, 130/80 should be my goal. Treatment of hypertension. There is no difference if you use an ACE, an ARB, a TCD, or a calcium channel blocker. But if you have kidney disease or proteinuria, you must use ACE or ARBs because they have been shown to decrease proteinuria and prevent the progression of CKD, chronic kidney disease. In African American, calcium channel blockers and diuretics are very effective, and many times, a 45-year-old, no kidney disease, I'm starting on calcium channel blockers, no different from ACE inhibitors. And keep in mind that most patients require more than one drug, and combination therapy is the way to go. And you can combine an ACE or ARB with calcium blockers or diuretics, and in about 70% of patients require more than one medicine. What about lipid management? Oh, this has been incredible changes, especially following the publication from the American College of Cardiology. And you should start management of lipid statin therapy in everybody who has elevated LDL. And you should check for lipids every 1 to 3 years for most people. And those who have over the age of 40 with an LDL greater than 100 should be on statin. Big discussions, should you start on 70? So we still have getting data, and most of us will want an LDL level of what's less than 70. But you must start treatment with the LDL is more than 100. And you should start moderate or high potency statins in most of these patients. Less than 40, only when they have multiple atherosclerotic cardiovascular risk factors of hypertension, hyperlipidemia, obesity, family history, or those who have cardiovascular disease. What about platelets? Oh, very important for secondary prevention. For primary prevention, not good. But for secondary prevention, somebody who already have cardiovascular disease or history of TIA, stroke, heart disease, the peripheral vascular disease, aspirin, a total daily dose of 75 to 162 milligrams is indicated. And dual antiplatelet therapy is reasonable in patients who have acute coronary syndrome. So, no, in the last 3 years or 5 years, we have great news. That's right. We now have medication has shown to have cardiovascular prevention or protection. So 10 years ago, we only care about efficacy. Bring the blood glucose down, hemoglobin A1C less than 7. In the last 5 years, 10 years, we say, safety is more important than efficacy. Hypoglycemia is associated with increased risk of death. Now our thoughts are, good, efficacy, safety, quite important. That then in patients who has cardiovascular disease or atherosclerotic cardiovascular disease, stroke, heart attack, heart failure, peripheral vascular disease, the use of GLP-1 and the SGLT2 has been shown to change or to improve the outcome in patients with type 2 diabetes. GLP-1, there are 3 studies. Here I have the liraglutide study, the semaglutide studies, and the albiglutide studies that is not on this slide. All of them shows improvement of cardiovascular outcome. All of these studies did or target MACE, major cardiovascular events that included acute myocardial infarction, cardiovascular death, and stroke. The leader trial with liraglutide versus placebo once daily in patients with high risk reduced MACE, these 3 things, by about 14 to 15%. Semaglutide, a once-a-week long-acting GLP-1, although this previous study was 10,000, this is only 3,000 patients, but the industry is doing a study in 10,000 patients to determine the cardiovascular benefit of semaglutide once weekly. And in this report, they shows a 25% reduction in MACE, heart attack, stroke, cardiovascular death. So GLP-1 were shown to have, and the albiglutide also shows similar thing. So GLP-1 effective. What about the SGLT2s? And we have here empagliflozin, canagliflozin, and dapagliflozin. 3 studies, and all of them shows cardiovascular benefits. So you have, to the left here is EMPA, and it shows that the MACE, cardiovascular, heart attack, strokes, death, but 15% reduction, similar to CAMBA, so canagliflozin. And DAPA did not show the primary event, but all of them show significant reduction in heart failure admission. If you have a patient with history of heart failure and diabetes, these are the type of agents that you should use in patients with type 2 diabetes. So again, these are the recommendations. Start monotherapy, metformin, lifetime intervention. If not good, it's not a goal in 3 months, you're going to consider dual therapy. And the dual therapy, before you decide, you ask, if the patient has atherosclerotic cardiovascular disease, yes, you go for SGLT2, GLP-1. If there's no, 70%, 75% of your patients, you can still use the sulfonylureas, the TCDs, the DPP-4, SGLT2, GLP-1, or insulin. So this is the message of 2019. So let me summarize what I told you. Criteria for diagnosis. 10 years ago, when we made this recommendation to implement A1C for diagnosis, we put it on the top of the ballot. Now we put it at the bottom of the ballot. Why? Because diabetes is the diagnosis of high blood glucose. And we want high blood glucose together with hemoglobin A1C. If you're going to use hemoglobin A1C, remember in African Americans, remember that they have higher hemoglobin A1C. We want combination, 2 tests better than 1 in most people. Prevention, lifestyle intervention. Oh, the CDC and many institutions are now implementing lifestyle intervention for prevention of type 2 diabetes. But if you have a 65-year-old male or female, BMI of 35, weight 180 pounds, and have not done exercise for 30 years, it's tough. Welcome. So in those patients who are not able to lose weight, in those patients who are not able to exercise, think about utilizing metformin, because metformin has been shown to reduce the risk of progression from prediabetes to diabetes by 30 to 40%. Check vitamin B12. I still have to remind myself to do that. Third, diabetes 101. We, for 50 years we have shown trying to push for efficacy. The last 10 years, safety. We now have medication who has great potential in bringing hemoglobin A1C down with no hypoglycemia or very minimal hypoglycemia risk. Hypoglycemia surpass the efficacy as you go, should always. And if you have somebody with hypoglycemia, please review the medication. Stop that sulfonylureas. Make sure that the dose of insulin is the right one for this individual. And nobody who has severe hypoglycemia, repeated hypoglycemia, should be in tight control. And as I mentioned, we have changed to cardiovascular disease prevention or protection, because now we have medications such as the GLP-1, the SGLT2 have been shown to reduce cardiovascular events, reduce the risk of heart attack, strokes, cardiovascular death, and for heart failure, the SGLT2 top of the line. And of course, these are the guidelines, that's right, what I mentioned before. Now, these medicines are expensive, some of them. So you still have metformin, sulfonylureas, and TZDs who are generic. They are okay, but there are some concerns related to weight gain, heart failure, sulfonylurea, hypoglycemia. But you can always go to the bottom of this slide, choosing your agent in the patients who do not have cardiovascular disease.